And the answer is sure, but I'd still want to emphasize that this is about your goals, not about my aesthetic nuances. But if you ask, then what I have more or less reached at this point is that I sometimes find that standard top procedures can lead to a little bit of a hollowing out of the chest and give it a little bit more of an operated look. And if that's what somebody wants, that's fine. But if somebody wants that sort of natural look, and I realize that that's a little bit of a loaded term, but if somebody wants a natural look, that generally means some more contouring of the chest and a little less of the flatness that you often see with standard procedures. And there's a reason for why the standard procedures will do that. Typically, a surgeon will go under the skin and identify a capsule, a very white structure that surrounds all of the glandular tissue of the chest, and follow that capsule along to remove the glands. And so it's a bit of a win-win. The surgeon has a roadmap, which is the capsule. We always like to have a roadmap during surgery. And you, the patient, get to get rid of the glandular tissue. But that type of technique tends to lead to slightly thin flaps, and it's the thin flaps that give that somewhat flat or somewhat hollowed out appearance. By leaving just a little bit of tissue behind, you can avoid that and give it more of a natural contour. And then the same thing is more or less true with the nipple grafting, which is, again, the most common procedure that, of course, is done in top surgery is a double incision with free nipple grafting. Most surgeons will do a very thin graft for good reason, because the thinner the graft, the easier it is to heal. But at the end, you can end up with a graft that's so thin that some people will call it like a postage stamp look, where it has none of the topography, none of the natural projections and hollows that you would expect to see in a nipple. And by leaving a slightly thicker graft, it's more likely that there'll be some scabbing and some peeling. But when that heals, and it invariably heals, it tends to have more of the topography of an unoperated nipple areolar complex, as we call it. So those are two specific nuances that I personally have become fairly fond of offering. There are others, like where you place the scar and where a groove would be expected in terms of the anatomy of the chest wall. But those are the things that I particularly focus and offer in my conversation with patients.